Sure. Good morning. My name is Dr. Jennifer Nara, N-A-R-A.
Go ahead, Councilman.
Thank you. Good morning, Doctor.
Morning.
Doctor, what do you do for a living?
I am a full-time forensic pathology consultant. However, I still do autopsies every month for Clark County Medical Examiner's Office.
So what is the relationship? Why are you doing them for Clark County, if you know?
Sure. Even though I do mostly consultation work, I still want to stay relevant, keep up to date, and still be practicing and performing autopsies, which is why my employer, ESI, contracts with Clark County.
Okay. And ESI, is that the same company that Dr. Burt works for?
Yes, it is.
And so, to become a doctor, I mean, obviously you had to do some things. You go through medical school?
Yes, I did.
Where'd you go to school?
So for undergrad, I went to the University of Washington in Seattle, Washington. And then I went to medical school at Western University of Health Sciences in Pomona, California.
And so you graduated from medical school what year?
Oh gosh, 2002. And then I went on to do my pathology residency, which is another 4 years. And that was at the University of Hawaii in Honolulu. And then to be a forensic pathologist, you have to do yet another year of forensic pathology fellowship. So I did that at Miami-Dade Medical Examiner Department in Miami, Florida.
Now, and then at some point you ended up, did you come up here for ESI or did you work for somebody else before you went to work for ESI?
Prior to working at ESI, a private forensic consulting company, I worked as a medical examiner for Spokane County here in Spokane, Washington.
Now, how did you get involved in this case? Was it for you didn't do the autopsy in this case, correct?
That's correct, I did not.
What was your role?
So at Clark County Medical Examiner's Office, anytime there is a case that's ruled as a homicide by one of the medical examiners, we are required to have another doctor, another medical examiner or forensic pathologist review the case. So it's kind of like a quality assurance, like a check and balance.
Is that what you did in this case?
Yes, I was asked to do that.
Did you review the autopsy?
I reviewed the autopsy photos, the report, and any investigative reports.
And that was at the request of the state, correct?
Request of the county, yes.
The county, okay. And now, how long ago did you do that review?
I believe the autopsy was performed back in 2024. I don't remember when the autopsy report was officially signed, but I would have been asked soon afterwards.
Okay. And have you reviewed the report recently?
Recently, yes.
And now you do both for the county. Do you also do private work sometimes?
Mostly private work, yes.
Okay, but you weren't hired by my firm, correct?
I was not.
And so, is there a difference in the kind of review you do? Let's say you're asked to do a quality assurance of a colleague. Is there a difference between that review and as opposed to when you're hired by a defense attorney, for example?
So doing the quality assurance, like I mentioned, the check and balance of another medical examiner's report here at Clark County, it's different from my regular consultation work, whether I am retained by a plaintiff or defense attorney. I am asked to scrutinize that case a lot more. I'll review all the findings of the pathologist who performed the original autopsy, just like I would for Clark County. But it's more in-depth because that attorney that hired my employer wants me to look for, could there possibly be anything that I would disagree with, anything that would be important to bring up.
Okay. Now, in this case, you were not asked to do that, were you?
To do the same kind of scrutiny, no.
And so you reviewed the report. You didn't find anything upon that kind of review. You didn't really disagree with anything in the report, correct?
But Dr. Burt's report, no, I did not.
So I'm going to ask you about a couple specific things. What is the difference between a hematoma and a contusion, if there's a difference?
So when we think of a contusion or a bruise, that's where you have some kind of pressure or trauma to your skin, so you get that discoloration under your skin because the blood inside your small blood vessels called capillaries, they break. So then the blood in those tiny vessels, they leak out into the surrounding soft tissues, and you'll see a bruise through the surface of the skin. Hematoma, that's slightly different. That's usually requires a significant more amount of force, so it could be from like a direct blunt impact or more direct pressure where you have more leakage of that blood that actually forms like swelling. Kind of like if you get like a goose egg from bumping your head against a cabinet drawer. That's going to form a hematoma versus just a bruise, which is usually not raised.
So fair to say you typically need something more like an impact rather than just pressure?
For a hematoma, yes.
Okay. Now, you've had exams where you found hematomas in patients, have you not?
Yes, autopsies, yes.
Okay. Is it your practice to put the fact that you found a hematoma in the report?
It is my practice to describe it. If I'm able to give some kind of dimension, I do that.
Okay, and you'll describe it as a hematoma, is that correct?
Hematoma, sometimes I'll use the word ecchymosis, but I will describe it as being different just because it's more three-dimensional versus just a simple bruise that doesn't cause swelling.
Are you familiar with, well, do you ever look at blood glucose level when you're doing an autopsy?
If it's available in the medical records provided, yes, I will take a look at that.
Is it useful in some cases?
In some cases, yes.
Okay. Are you aware, not from the autopsy, did you see where the blood glucose level was mentioned in the autopsy?
I honestly do not recall the blood glucose level being specifically mentioned.
And let's just, I'll give you an example. Let's say it's a blood glucose level of 300. It's what the paramedics, the initial reading they would have taken just at the very beginning of life-saving efforts, 300.
Okay.
Have you ever seen a level like that in an autopsy?
From the paramedic report, yes.
Okay. And is it uncommon to have levels that high?
That's much higher than normal.
Okay. And would that be consistent with a grand mal seizure, for example?
When we see elevated glucose levels, your glucose level should be about like 100 in general, depending on how the lab calibrates the range. Level 300 is high, so if the patient's not a known diabetic, doesn't have diabetes, and we see a level that's that elevated, then we think, okay, well, are they a trauma victim? We frequently see high glucose levels in people who are involved in a car accident and come to the emergency department, or paramedics at the scene. They'll take a quick level, and it's frequently elevated.
Okay. But now, what is a seizure, by the way? Can you just explain what that is?
Seizure, I'm sure you've seen this on TV and movies, where it's like an involuntary movement, typically of the body parts. With grand mal, it'd be the entire body. Sometimes it could just be portions of the body. Sometimes you could barely see movement, but it's caused by abnormal activity in the brain, most commonly due to lack of oxygen, because your brain is the one organ in your body that desperately needs a lot of oxygen. So it's abnormal activity in the brain.
Now, let's say it's a grand mal seizure with the arch position. You familiar with that?
It's grand mal, yes.
A full body seizure. Could that spike your blood glucose level to that level?
A grand mal seizure with your whole body movement, yes, that can definitely raise your glucose levels because it's stressing your body.
Okay, 300 level, not unexpected?
It's not.
Could it be higher?
It could be higher.
Now, are you familiar with a hypoxic seizure?
Yes.
Okay, what is that?
I think I briefly touched on this just a few seconds ago. Hypoxia is lack of oxygen to the brain, and the brain is the one organ that needs the most amount of oxygen more than any other organ in the body. So if the brain doesn't have enough oxygen, it can have seizure activity. So we call those hypoxic seizures.
Okay. So if a person has a heart attack, the heart stops pumping. It's not going to get blood or oxygen to the brain anymore. Is that correct?
Correct.
Okay. Would that result in a hypoxic seizure?
It can.
when you get patients, do you call them patients, the people you work on?
I do.
Okay. When you get patients who have been through life-saving measures like EMS procedures, do they sometimes have injuries?
Sometimes, yes, they have injuries.
What kind of injuries do you see?
Oh, it depends on what kind of CPR is used, how long they've been doing the CPR, the age of the patient. Frequently, you'll see bruising. That's probably the most common thing you'll see. You'll see rib fractures on the chest. And depending on how long the CPR is going on, sometimes they'll have injury to the liver and the spleen as well, because it's in that same general area, as well as you could have bruising of the heart.
And now, you're familiar with the Lucas device?
I am.
Okay, and it's a pretty effective machine?
It appears to be. It's pretty loud.
Okay. Does it, from your training experience, does it provide sufficient blood flow to at least enable life-saving efforts?
I believe it does. The medical literature supports it, which is why it's used.
Okay. Is it known to cause any injuries, that device?
Lucas device, along with any other mechanical device and even manual CPR, yes, it does cause injuries.
What kind of injuries?
Could cause same type of injuries that I mentioned, such as bruising. It could cause petechial hemorrhages. It could cause rib fractures, probably more frequently, and also injury to the injuries of the chest and abdomen as well.
You said petechial hemorrhages?
Yes.
Is it the same thing as petechia?
Yes.
Okay. And the now are you familiar with the plunger on the Lucas?
Yes, I have seen it.
Okay. And what is your understanding of what is at the very end, the part that comes in contact with the body? What is that portion?
It's like a suction cup, so it'll like pull your soft tissues up and down.
Okay, so push down and then actually pull up.
Yes.
Okay. And that's something that actually regular manual compressions can't do, isn't it?
The pulling up part, no.
Okay. And that, what benefit, I mean, why would there be a suction cup? What benefit is it to have the chest pulled up instead of just pushed down?
That when you're pulling up, that's going to allow for more blood flow, which is what you want.
Okay. And what is perfusion?
Perfusion is just notice a medical term or fancy term for having enough blood flow to allow oxygen to go to your organs.
And so with the Lucas device, would that enable perfusion or at least make it the possibility of perfusion a little better?
That's the purpose of it, yes.
Now, you're familiar in your work with risk factors, like what might place a person at health risks, correct?
Yes.
And sometimes people can just have a sudden first-time heart attack that we don't see coming and pass away, is that correct?
Unfortunately, yes, we see that.
And in this case, do you recall, the age, the height, and the weight of Marcy in this case, Marcy West?
Miss West, I knew she, at the time of autopsy, she was 48 years old. I unfortunately don't remember the exact height and weight.
Does 5'10", 180 pounds sound about right?
She was fairly
188 pounds, I'm sorry.
tall and on the slightly heavier side.
Okay. So those dimensions, if a person has fatty liver disease, is that a risk factor?
Risk factor for?
For like some kind of health problem?
Fatty liver, yes, that can increase your risk for sudden cardiac arrest.
Okay. And how about high cholesterol?
High cholesterol is very well known to also increase your cardiac disease risk.
What about having a resting heart rate of 95?
95 is higher than normal. I'm hoping mine's not that high. That also would increase your risk.
Okay. That's also known as borderline tachycardia, isn't it?
Yes.
And what is tachycardia?
When your heart rate is beating faster than it normally should.
If the person we're talking about has frequent chronic migraines, nausea, throwing up, if you put those together, does that inform you at all about whether or not there's some kind of red flag for health concerns or health risks?
They have chronic migraines, nausea and vomiting. I mean, those are not normal symptoms to have chronically. So yes, there's probably something going on.
So they're not causes, they're just symptoms, is that right?
Correct.
Now, the practice of doing an autopsy is not a perfect, exact science, is it?
I don't think any practice is a perfect science, unfortunately.
Okay. And two different medical examiners could look at the same body, the same information, and reach completely different conclusions.
That can happen, yes.
Are you familiar with injuries? Do you ever run across bodies with injuries to the esophagus or to parts of the throat?
Yes.
And how about injuries to the esophagus specifically? You've seen that before?
Yes, many times.
And in your practice, if somebody has had life-saving measures, let's say not intubation, but they've had like an eye gel, do you ever see associated trauma or any kind of injury to the esophagus with that?
I have.
And now the parts of the throat, can you kind of describe what we're looking at on the parts of the throat?
Sure. So what you can feel, obviously more prominent in gentlemen versus ladies, your cartilage here, upper here would be your thyroid cartilage. Your thyroid glands over that. Right below that, your cricoid cartilage, and then you can feel your windpipe. It's kind of got like a corrugated texture, and then behind that is your esophagus.
Now, injuries to this region, does it take a lot of force to cause injury to that region?
A lot of force? No, not necessarily.
Is it pretty delicate?
Your neck in general is a pretty delicate area.
And when you look at, there's a little bone in our throat. What is that called?
Higher up in your throat, there's a bone called the hyoid bone. It's kind of wishbone shaped.
Okay. Oh, so that's the human wishbone.
Yes.
Okay. If there's like an airway asphyxiation, is it common to see damage to that bone?
Sometimes you will see damage to the hyoid bone, sometimes you will not.
Either damage or will you see dislocation?
Depending on the age of the patient, usually you'll either see hemorrhage or some kind of fracture, dislocation.
Okay. So, in a situation of let's say if we occlude both jugulars, we occlude both carotid arteries, and we do that long enough, how long would it take to cause unconsciousness?
If you push on both sides of your carotid really hard, and I don't recommend doing that right now, within several seconds you'll pass out.
And how long would it take to cause death?
You'd have to apply continuous pressure for a few minutes.
5 minutes, 10 minutes perhaps?
Depending on the person.
If that were to occur, well, what is the vertebral arteries? What are they?
So they're the arteries, they connect to your carotid arteries on both sides of your neck, and they're the blood vessels that feed your brain, so they go straight up on both sides.
Okay. And they're protected by bone, correct?
Bone, lots of soft tissue, yes.
So easier to occlude the carotid and the jugular than it is the vertebral artery.
Yes.
So if you're occluding the jugular and the carotid artery, you still have blood pumping up. Typically, you still have blood pumping up through the vertebral arteries, don't you?
Depending on the pressure applied, you could still have some blood flow through those vertebrals.
And that would cause pressure to continue building.
Depending on how long they're being compressed.
Well, long enough to kill the person.
Right.
Would you expect petechia?
Sometimes you will see petechia, sometimes you don't.
Now, if there's a heart attack, let's say cardiac arrest, I'll give you two situations. Let's say the heart stops because there's no oxygen to the brain. Situation one. Situation two, the heart stops for like some kind of natural heart attack, first-time heart attack, whatever. It just stops. You have a cardiac arrest for no external cause, just internally. When you compare those two hearts, are they going to look different? You're going to be able to tell the difference one from the other.
In general, you won't see a difference in the heart. I mean, not unless there's some trauma or some underlying major heart abnormality. Like if you have a blood clot, that travels to the heart.
If you suspect a seizure disorder, is that something that you can always determine by just looking at the brain, for example?
Unfortunately, no.
And in order to kind of rule out to the best that you can, to the best of your ability, what would you have to do with that as a pathologist? What would you do?
Depending on the case, especially if someone has a history of seizure disorder, I may send that brain out to a neuropathologist for them to do an examination. They'll examine the inside and outside of the brain, and they'll also take microscopic sections and look under the microscope for anything that's abnormal that they could possibly see.
But the only way to really rule it out would be to do that procedure.
Yes.
Now, in order to confirm that petechia is petechia, you need to cut the petechia out to make a conclusive determination.
I think if the pathologist has enough experience, like I know I'm pretty confident if I see petechial hemorrhages on a patient, I know that's petechia, and I won't be cutting everyone's petechia out.
But if you're not sure, the only way to be sure would be to cut it out, correct?
If I'm not sure, yes, I'll cut into it or I'll cut it out.
How long does it take to cut it out and examine it, confirm it or not confirm it?
If you include the laboratory processing time, because you gotta
Well,
send it out to the lab.
How much of your time does it take?
Well, once I cut it out and it goes to the lab and they process it and puts it on glass slides, and then I look under the microscope, I'll know within seconds.
Okay. And as far as sending the brain out to a neuropathologist, how much of your time would that take?
We send out, it goes out of state, and unfortunately it takes several months to get those results back.
But you don't have to take it out of state, you send it, correct?
We send it, correct.
How much of your time does it take? You got the brain, it's in your hands. How much of your time does it take to package it up, send it off, and then review the results when it comes back? Just that part.
That part, it won't take me that long. It's just the waiting, which is still time.
Okay, but your actual work, the amount of time it takes you out of your day, is it more than 15, 20 minutes?
No.
Is it, as far as the timing of an autopsy goes, ideally, how soon should you do an autopsy after a person's died?
In a perfect world, it would be right after their deceased, but that pretty much never happens.
But what is the, I mean, I know we're not waiting months and months and months. What is the danger of waiting more time? If you do it later than sooner, what's the danger?
I think it depends on the case. Like if it's a toxicology related case, some medications may break down the body and the levels may be different if you wait like 2 weeks to do the autopsy and draw the blood versus doing it within a couple days. Someone who's been shot multiple times, if we don't get to the body for, I don't know, several days, the gunshot wounds, entrance versus exit, sometimes they may be a little bit more challenging to decipher which one it is. So it really depends on the case.
Is decomposition of the tissue a concern at all?
That's always a concern.
You're familiar with the term blanching, correct?
Yes,
What is
blanching.
blanching?
So blanching, I'll give you an example with livor mortis. When your blood settles in after you pass away, it kind of has this purplish discoloration. If you press on someone whose lividity is not fixed, they haven't been dead for a long time, you'll see the imprint of your finger. I mean, I could even do it top of my hand. I'll see blanching when I'm pressing down on my hand, and I'll see it's kind of lighter for where my finger was pressing down.
Now, a person who has a blemish on their face, like, let's say, will it blanch when you press on it typically?
Blemish, like a big freckle? No.
Does petechia blanch?
did get a really tiny pinpoint hemorrhages, so if you press on it, I don't see that it's going to change.
So there's no blanching to be expected there.
Correct.
And I mentioned the different risk factors that we talked about. How about if someone leads a sedentary life? Is that also a risk factor for a 48-year-old person who's somewhat out of shape?
Sedentary life, yes, that's a risk factor.
I've heard sitting is the new smoking. Is that true?
I don't know about that, but
Now, in the case of a struggle, are you familiar with what would be considered defensive wounds?
yes.
And what are those?
Defensive wounds, we typically see that in individuals who are being attacked or going to naturally protect themselves. You'll put your hands and forearms up, and you can get, if someone's coming after you with a knife, you'll get stab marks, cut marks on your hands and on your forearms. If you're being beaten, you're trying to ward off an attacker, you can get bruising also on your hands and forearms.
There could also be scratches, correct?
Correct.
And now, you don't have a way to determine how old a bruise is by looking at it, is that correct?
Oh, there's literature out there. I'm trying to date bruising, and there's conflicting information because in general, we can say if you see like purple blue discoloration, that's a fresher bruise than one that's turned more yellow and brown. But some bruises will turn like a brownish discoloration almost right away. It really depends on the individual.
And a bruise can continue to form with just the Lucas device going, is that right?
The Lucas device, if it, as is pressing down the chest, that could break blood vessels. You could have blood leaking out to the soft tissues, yes.
Well, if there's an injury and the heart stops immediately, there's no blood flow, would that stop the formation of a visible bruise?
If you have post-mortem some injury to a blood vessel, you're still going to have whatever blood that's contained in there leak out, and sometimes you can see that under the through the surface of the skin.
Is the Lucas device or compressions going to make it more likely that blood flow could assist with the bruise formation process?
I don't know if I could say more likely or less likely. The purpose of the Lucas device, one of the purposes is that it does move the blood around in the blood vessels.
Thank you. That's all the questions I have. Thank you.
Cross-examination.
Morning, Dr. Nara.
Morning.
You also perform autopsies on a contract basis for Clark County, is that correct?
Yes, that's correct.
And defense indicated you peer-reviewed Dr. Burt's work in this case, did you not?
Yes.
And that included her case file, photographs, reports, something like that.
Yes.
Can you describe the process by which you peer review an autopsy?
Sure. Whenever that request comes in, I review the autopsy reports against the all photos, autopsy photos. If there's photos from the scene, if law enforcement sometimes they'll take separate photos as well. The Clark County medical examiner investigators, they'll produce a report, so I'll take a look at that. And if there's any other like notes in the system that I need to be aware of, I'll review that as well. If there's videos, I'll take a look at that. So that's the same thing for when I do a case that I classify as a homicide. I know another doctor's going to review all that material as well.
That's standard practice in Clark County to have homicide autopsies peer reviewed?
Yes.
And is that done prior to the autopsy being officially disseminated?
Yes, that is required.
And what happens if you disagree with the findings of the original autopsy?
It hasn't happened at Clark County with me. I know at other jurisdictions, if there is a disagreement between the two doctors, I believe the director of operations of the office will bring in a third doctor.
And so in reviewing Dr. Burt's autopsy in this particular case, did you concur with her finding of hemorrhaging to both carotid sheaths?
Yes.
Did you concur with her finding of hemorrhaging to the esophagus?
Yes.
And if the hemorrhaging to the esophagus were caused by the use of the eye gel, what would you expect to see as far as that injury?
From the eye gel, I have seen injuries from even from eye gels, and they have like a softer tip than the regular ET tubes. You'll have some hemorrhage in the surface, the inner lining of the mucosa. It'll be pretty focal.
So you would expect it on the inside of the esophagus, not the outside of the esophagus, correct?
Correct.
And do you have any reason to believe in this case that the eye gel caused the hemorrhage to Marcy's esophagus?
If the injury was not to the inside, no.
And you reviewed the cause and manner of death that Dr. Burt indicated?
Yes, I did.
And what was her cause and manner of death?
Gosh, I don't know the exact wording. I would have to look at the reports.
Was it asphyxia due to blunt neck trauma?
Asphyxia, yes.
Okay. And why did you concur, did you concur with the cause and manner of death that she reported?
As I stated earlier, yes, I did.
And why?
That's based on my review of all the photographs, the investigative reports, the videos, and any information about the circumstances of the case.
So it's your expert opinion that this was asphyxia due to blunt neck trauma?
Yes.
Now, is a hematoma a type of contusion?
Hematoma, a type of contusion. Yes, it's a contusion with swelling, and there's more blood out into the soft tissues.
And would the photograph of the injury be the best indication of the dimensions of the injury?
It usually is.
As far as the hyoid bone is concerned, defense counsel asked you about damage to a hyoid bone in an airway strangulation. Is that an expected injury in a vascular strangulation?
No.
Why not?
From my experience and from the common forensic pathology textbook, we don't often see that because there's no direct injury to your wishbone, to your hyoid bone. That's like more central.
If a patient had no history of seizures, would you necessarily send the brain out to another provider?
I think I also mentioned that earlier. If they don't have a history, or if they do have a history, then I probably would send it out. If they don't have a known history and I don't see anything abnormal, I probably wouldn't.
Why not?
It would depend on the circumstances of the case. If there are other reasons, if I have other evidence in the case to point to the seizure not being the number one cause, then that's not something I would send out.
And are you able to examine the brain as a forensic pathologist?
Yes.
And you could see at least grossly visible injuries or things that could have caused a seizure to the brain?
Like traumatic injuries or masses such as like cancers, yes, those are things that we could see. Sometimes, as I mentioned earlier, we can't always see a seizure focus if there is something that causes seizures.
And defense asked you about hypoxic seizures. Can strangulation also result in a hypoxic seizure?
Strangulation, which will limit or eliminate oxygen to the brain, that could cause seizures.
Do you see any issue with doing an autopsy within 3 or 4 days of the death?
No, that's frequently what happens at Clark County.
Do you routinely do autopsies in that period of time?
Yes.
Is there anything in her case or the case file for Marcy West that indicates to you that any of her injuries were caused by resuscitation efforts beyond the mark from the Lucas device on her chest?
The injuries that were documented by Dr. Burt in the neck, no.
Is there anything in the case file for Marcy West that indicates to you that she died from a seizure?
No.
Is there anything in the case file for Marcy West that would lead you to believe that Marcy died from natural causes?
From the entire case file, no.
I have no further questions.
Read the record. Thank you. And doctor, you said you agreed with the finding that there was injury to the carotid, correct?
Yes, the neck.
Okay, but the only way to confirm it would be to cut into the carotid sheath, correct?
confirm it, you can confirm it that way. I believe you asked me that. But otherwise, when you see, we could see hemorrhage with the naked eye.
Okay. But to confirm, you need to really cut it and look at it and so forth, correct?
I'd take a good look at it, yes.
Okay. And is there a problem with cutting into the carotid sheath?
We always try to be careful not to cut into the carotid arteries themselves just because they're used for embalming. So we always like think ahead for, the patient's families. But if we see obvious hemorrhage around there, the doctor doesn't necessarily have to actually dissect it out, if that makes sense.
Okay. Well, it does. And so you can just kind of assume it is because of the hemorrhaging, correct?
Yes.
Okay. But you're not going to take the extra step because you're thinking about the appearance of the person's face and what the family might see.
That is something, if we don't think it's critical to the cause of death.
Now, you said if there weren't a history of seizure disorder, you wouldn't necessarily send the brain out, correct?
If there were not, correct.
But if the claim that somebody was there, somebody who is a medical professional said it was a seizure,
I'm sorry.
if the evidence was that a competent medical professional were there and said it was a seizure, in that situation, would you send the brain out to rule out the seizure as a cause?
That's a good question. If there was some documentation in medical records of a patient, then I'm pretty sure that doctor may want to know if their patient died of a seizure, so I may send it out, but it's really a case by case.
Sure. But now in a case where a person doesn't have a lot of medical history, they haven't been for a regular checkup in about 7 years, and you don't really have that information, or at least 7 years, you don't have that information, then you wouldn't be able to know from the medical records whether or not there's a seizure disorder, correct?
Correct. Unfortunately, that happens with a lot of patients,
Okay, so what happens with a lot of patients?
where not everything's documented, and unfortunately, it's not something routine for us to send the brain out on every patient. So it's only if they have some kind of history and, or if they have some kind of obvious abnormality, and I want to have a neuropathologist take a good look at it, I'll send it out.
So the history is only going to be based upon the medical records and the times that they've actually gone to see a doctor. A doctor's made an examination.
I object is to leading questions.
And the doctor's reflected that examination records. That's the history we're talking about, right?
Yes, something documented, yeah.
And a person could develop a seizure disorder later in life and it be undocumented, couldn't it?
Unfortunately, yes.
Okay. Is it always something that's obvious, or is it something that can start small?
It's not always obvious.
And then seizures can be momentary. Is it true that seizures can be momentary and unnoticeable to the person experiencing one?
Yes, we call them absence seizures.
In this case, you didn't really actively and affirmatively look for other causes, correct?
Object is to leading questions.
Did you, that's a great question. Go ahead, sustain or show, okay, I'll just say your question. Did you actually look for alternative causes as an alternative to what Dr. Berg found?
When I reviewed the photographs, I was trying to think, is there something else that's really obvious that should have been considered? Those are things that will routinely go through our head when we do a check and balance or a QA.
Did you look for things that weren't obvious?
That weren't obvious, such as, I'm sorry.
The other doctor, did you make a concerted, long-term effort to find causes that were not obvious, as you would if you were working for the defense, for example?
I pretty much just reviewed all the photographs and information regarding the circumstances of this case in my review.
Just kind of sign off on what Dr. Berg had already done, correct?
But reviewing them against all the photos, documented evidence.
Now, I don't know much about your history. Did you ever work in a hospital?
During my training, yes.
Okay. So, as a medical student,
Medical student, resident, it was a while ago.
okay, when was the last time you treated a live patient?
Oh my gosh. I'm gonna be dating myself, probably back in 2004.
Okay, so 21 years ago, 22 years ago?
Yeah.
Okay. Is it helpful to have a patient's history when you're working with a live patient?
Live patients, clinical doctors, yes, they need the history.
And that's important when you're treating a person because you want to know how to treat them, is that right?
Get the background information of patient, yes.
And that's something, other than medical records, if you have them, you don't have that with a person who's dead unless you talk to the family or something like that?
Family members, sometimes we will have medical records available to us at the time of autopsy. Most of the time we'll get them afterwards.
Did you talk to any family, or do you know if Dr. Burke talked to any families in this case?
That I do not know.
Now, you mentioned, you said earlier that it's not an exact science, right? Would you agree that autopsy work is more a matter of interpretation?
Objection deleting.
Okay. Are you working with a person who's died, are you working with all the information that you would need if you're working with a live patient?
Objection relevance.
Okay. Okay, that's all I have. Thank you.
Recall?
No, Your Honor.
Can the witness speak excused?
Subject to recall.